start?
Ma'am, after the introduction, I will hand over the session to you. So good evening and a warm welcome to all the dignitaries present here. I'm Sremshi from Planet, serving as the allopathic session assistant to ensure a seamless experience. Planet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Planet serves as the digital partner for this event hosted by the National Neonatology Forum, and the focus of today's session is NNF Shine Week 3 Central Zone. So let's begin today's session, for which I would like to invite Dr. Sapna ma'am to take over. Over to you, ma'am.
Yeah. Good evening, one and all. Greetings from NNF India for this new NNF Shine program. Whether I'm audible now? I'm audible? One of you can unmute and say whether I am audible.
Ma'am, is there any issue?
Yeah. So today we'll be discussing about care of low birth weight babies. In India, we know India is one of the country which has highest number of preterm low birth weight babies, and even small for gestation babies. We have higher incidence of all these low birth weight, preterm and small for gestation age in our country. And these babies are not only have to be cared in the medical college or the tertiary care center. As we have more number of babies, all these babies should be managed at even at the district or the community health center level. So that is why this chapter is very important. If you take India, there are about 18% of the babies are born low birth weight, and 13 to 14% of the babies who are born are preterm babies. So first we have to know what is the definition. For statistical purpose, we define low birth weight babies are those babies who are born at if their birth weight is less than 2.5 kg at birth. Then when do we say the baby very low birth weight? If the birth weight of the baby is less than 1,500 grams, then we call that baby as very low birth weight. And we say that baby is extremely low birth weight baby when the baby's weight is less than 1 kg at birth. So why do you want to know this classification of the weight? Because we have to prognosticate the parents at birth. Whenever we are attending the delivery calls, when we go and see the baby, we should tell the prognosis. As the gestational age, as the weight of the baby is to be low, this baby is going to have more morbidities and mortality when compared to the baby who is normal at birth.
Dr. Sapna, I think the too many noises are coming from other. So I request Tracy from ClearNet to mute all.
Yes, sir. Some background noise is coming, but I am not able to hear anything from that.
Tracy, please, Tracy, आप अपने आप को mute करो. Tracy from ClearNet. Tracy from ClearNet. Okay. You just carry on. I'll ask somebody to get her muted. Yep.
Yes, sir. So one kind of classification is based on the weight of the baby. The other classification is based on the gestational age. When do we say the baby is a preterm baby? So if the baby is born less than 37 completed weeks, then we call that baby as a preterm baby. And if that baby is born less than 28 weeks, then we call that baby as an extremely preterm baby. And if the gestational age at birth is 28 to 32 weeks, then we call that baby as very preterm. From 32 to 37 weeks, we call that baby as moderate to late preterm. And we call that baby as term when the gestational age is between 37 weeks to 41 weeks plus 6 days. And when the baby is born at more than or equal to 42 weeks, then we call that baby as a postterm baby. So whenever we go and attend the delivery call or see a neonate, we have to classify. One is based on the birth weight, whether the baby is normal birth weight or whether the baby is a low birth weight. If it is a low birth weight, then whether that baby is extremely low birth weight or very low birth weight. And the second classification, what we have to do is based on the gestational age, whether the baby is born at a preterm or a term gestation. Because we all know that preterm babies have more complications, not only during the neonatal period. For example, their outcome, like they may have respiratory distress, feeding difficulties, sepsis, but even at the later age, these babies have to be followed up for a long time. So babies who are born at lesser gestational age, they need long-term follow-up because their neurodevelopment, their cognition, and other are not going to be like a term baby. So we have to follow them and do the appropriate intervention as per required. So why do the babies, what are the types of low birth weight baby? So a baby can be low birth weight. Either it could be due to prematurity because they are born early, less than 37 weeks, or they are small for gestational age. In India, we see both the things, both prematurity we see and small for gestational age also. So when do you say small for gestational age? If they are born, if their birth weight is less than 10 centile for the gestational age and six. Here we can see one baby who is on the left hand side of the screen is a preterm baby. Right side we can see the baby is a small for gestational age. There is another entity called as intrauterine growth restriction. So many of the times we have a confusion. What is the difference between IUGR and SGA? So when you say IUGR, that means that baby is not reaching the growth potential which the baby is supposed to reach. So we can define IUGR mainly when you have serial scans. So when they are doing antenatal scan, so based on the gestation, first trimester, second and third trimester, we estimate the weight of the baby. So serially, if you are doing two measurements, and if these two measurements are faltering down, then we call it as intrauterine growth restriction. Whereas small for gestational age is a single measurement and it is for a statistical definition. And IUGR babies will be more merasmic. Like for example, when you see the babies, you can see that they don't have buccal pad of fat. Their bones are visible for us. They don't have any fat. They have large head. So those are features of intrauterine growth restriction. So when you say SGA baby, it can be either constitutionally small. For example, if the mother is small, the mother is young age mother, the mother undernourished, father is unnourished. In that case, we have a baby who is small for gestational age, which is called as constitutionally small for gestational age. And these babies will have better development and for a better outcome in terms of growth and development when compared to a baby who is intrauterine growth restriction. So that's why we have to know whether we are dealing with an preterm baby, whether we are dealing with a small for gestational age baby, or whether we are dealing with an intrauterine growth restricted baby. So how do you know whether the baby is appropriate for gestational age, SGA or LGA? So whenever we attend the delivery of a baby, we have to, after once the baby is stable, then we have to take the weight of the baby. Once you take the weight of the baby, we have to plot it according to the gestational age. So this growth chart which is shown here is an intergrowth charts. So we have various types of charts. One of the chart which is recommended is intrauterine growth chart, which is a standard growth chart which has been developed in many countries, and India is also a part of this growth chart. So, for babies or born more than 33 weeks, we can use intergrowth charts. If you have a smaller baby less than 32, then we can use Fenton charts. So here I am giving two examples. Here you can see baby A who is born at 35 weeks of gestation and the baby's weight is 2.2 kg. So here we have centiles like 3rd centile, 10th centile, 50th centile, 90th centile and 97th centile. So if the baby's weight is between the 10th and the 90th centile, then we call that baby is appropriate for gestational age. See here the baby is 35 weeks. The baby's weight is 2.3 kg. So it comes under between the 10th and the 50th center. So then we call this baby is an appropriate for gestational age baby, but it comes under low birth weight because the weight is less than 2.5 kg. So if you have another baby who's born at 35 weeks, but the birth weight of the baby is around 1.5 kg, then it comes under what? Small for gestational age. Because if you take 1.5 kg here, 35 weeker, 1.5 kg, then it is coming under less than third centile. Then that is severe IUGR or severe SGA. So then you have another baby. For example, you have a baby who is born at 38 weeks. The weight of the baby is, for example, the weight of the same baby, 2.3 kg. Then even though baby is born at 38 weeks, the weight is only 2.3 kg. Here, this baby is called as an SGA baby because the weight of the baby is below the 10 centile. So at delivery, we have to mark whether the baby is an AGA baby, SGA baby or an LGA baby. So we say LGA when the baby is more than 98 percentile. So I think it is now clear. So we have to mark the growth chart at delivery. So once you know that baby is a low birth weight or preterm delivery, we have to elicit in history what is the reason for the prematurity or low birth weight for the babies. So the causes vary. Some of the causes is related to the mother. Some of the causes are related to the fetus. So what are the reasons why a baby can be born prematurity? So one of the major risk factor is if you have a mother who has previously given birth to a preterm baby, there is a high chance that this pregnancy, she is going to have a baby who is born preterm and earlier. So last time if she has delivered at 32 weeks, this time she can even give birth before 30 weeks. That we should know. So, and if the extremes of age, if the mother is less than 18 years or a younger mother or elderly priming, then there is a high chance the baby is going to be low birth weight or preterm baby. Underweight or overweight in terms of nutrition, extremes can also cause low birth weight and prematurity. And one of the major reason nowadays is multiple pregnancies because of IVF conception. We see multiple pregnancy, and one of the common complication in these is a growth disparity between the babies because of sharing of the placenta, and they are also born preterms. Another is any stress or during pregnancy, and uterine anomalies or cervical anomalies can lead the mother to have a preterm delivery. Substance abuse, cocaine abuse, chronic cigarette smoking, alcohol abuse, all these can also cause low birth weight and prematurity. And any infection in the mother, like urinary tract infections, if the mother is having malaria or some torch infections, there is a risk that baby can be low birth weight or preterm delivery. And chronic maternal conditions like diabetes, hypertension, or if the mother is having some renal disease, or if the mother is having SLE, all those things, there is a risk of low birth weight and prematurity. And we all know now, because of stressful life events, the baby can have premature, they can be born at preterm. Apart from these, if the fetus is having some chromosomal abnormalities or intrauterine infection, there is a chance that the baby can be low birth weight or small for gestational age. So we have to elicit the history to know what is the reason, so that next pregnancy, whether there is a high chance of recurrence or not, we have to elicit. And during antenatally, if you know this mother is going to be at high risk of preterm delivery, we can take more precautions for the mother. We can refer her to a higher center so that she can register in a higher center where she can undergo serial monitoring of the weight of the fetus and required antenatal steroids. So all those things will happen only if you know which mother is going to have a preterm delivery. So once you, sometimes we may not know the gestational age of the, when is her LMP, then we have to estimate the gestational age of the baby, or sometimes the mother may have not appropriately giving the irregular menstrual cycle. So how do you estimate the gestational age of the baby? One is, we all know from MBBS days, when is the last menstrual period. If the cycles are regular, then if the mother remembers their LMP, one way of estimating the gestational age is LMP. That is from the last menstrual period, 9 months plus 7 days gives the date of delivery. From that, we can calculate the gestational age. But if the mother is not sure about the last menstrual period, or if her cycles are not regular, then one of the way of estimating the gestational age is antenatal ultrasounds. So especially the first trimester ultrasound scan. So if the scan is in the first trimester scan, the parameter which helps in determining which has high sensitivity is crown trump length. It is more sensitive. So we have to take the first trimester scan and see what is the gestational age. Scan before 13 to 14 weeks of pregnancy is best in predicting the gestational age of the fetus. Then on examination, once the baby is born, then we have to do the expanded new Ballard score, which is both physical and the neuromuscular score. This can be applied from 20 weeks of gestation. So what are the parameters? So as a pediatric postgraduate, all of you should know how to do the new Ballard scoring. So this is best, it is eye sensitive when it's done between after 24 hours to 24 hours to 48 hours. So second day like that, if you do, it has a best prediction of predicting the gestational age. You can do up to 7 days, but best is between 24 to 48 hours. So physical parameters. So once you see a baby physically, we can differentiate whether the baby is a term baby or a preterm baby. But if you want to know the correct gestational age of the baby, for example, you want to know whether the baby is born at 30 weeks, 32 weeks, correct, then you have to do both the physical and the neurological parameters. So new Ballard scoring has 6 physical parameters and 6 neurological parameters. So what are the physical parameters? One is the skin. You know that when a baby is a preterm baby, the skin will be very thin. We can see the underlying veins of the baby transparent. It will be jelly-like if you touch the skin of the baby. Whereas a term baby, the skin will be thick, non-gelatinous and keratinized. So then it is the hair of the baby, where you can see the abundant growth of hair. So especially the hair which is seen on the fine hair, immature hair, which is seen on the back of the baby is the lanugo hair. So lanugo hair will be abundant in a preterm baby. But as the baby gestation age increases, as the amniotic fluid volume comes down, because the back of the skin, baby touches the uterus, rubs against uterus, it will get bald up, the hair gets removed off. So what we see is a baldness. As the gestation age increases, the hair will be bald. And then we have to examine the ear cartilage. How is the ear cartilage? So in a preterm baby, it will be very soft. It will be devoid of cartilage. So as it is devoid of cartilage, when you just press it and release it, it goes very slowly. Whereas in a term baby, there will be an instant recoil. Then we have to palpate the breast nodule and see. So in a preterm baby, the breast nodule will be very imperceptible. We cannot palpate in extreme preterm babies. Then little small amount of breast nodule is palpable. Whereas in a term baby, we can see a thick breast nodule and areola also well formed. So that is one thing. But the problem in breast nodule is, for example, if you take an intrauterine growth restriction baby, as vital organs get adequate nutrition, if you take an IUGR baby, the breast nodule may be small. So the main thing we all should know that we cannot do the gestational age parameter by looking 1 or 2 parameters. So we have to see all the parameters so that you will get the correct idea. Because if you see only the breast nodule may not be, maybe very small in an IUGR baby. So then you have to see the plantar creases. How is the creases developed over the sole of the baby? So in a preterm baby, for example, if you take an extreme preterm baby, the sole creases may be fairly, they are not seen. Then we can see some sole creases developing over the anterior 1/3 of the sole. And as the gestation age of the baby increases, term baby, we can see the sole creases over the entire sole. Then we have to see the genitalia, where how is the male baby, how is the scrotum developed, what are the rugosities. In a term baby, you can see a well-formed scrotum. Testes will be descended into the scrotum. Whereas in a female baby, the labia minora will be covered by a labia majora. Whereas in a preterm baby, we can differentiate labia majora from labia minora, and clitoris also will be prominent. So based on these 6 parameters, we can know the whether the baby is a preterm and term baby. Then comes the neurological parameters. So in neurological parameters from head to toe, if you see, we have what is the posture of the baby. Then we have arm recoil, scarf sign. Then if you come to the lower limb, popliteal angle, heel to ear. So all the 6 parameters we have to see to know the gestational age of the baby. Because when you know the gestational age, one is to know what are the complications this baby is going to get, and also to tell the prognosis in terms of how many days the baby may stay in the NICU, what are the various morbidities the baby is going to face in the NICU, and what is the long-term risk, and how many days the baby should be followed. All depends upon the gestational age of the baby. So once you know that baby is a preterm or low birth weight baby, there are some morbidities which you have to look for when the baby is in the NICU. One is birth asphyxia and respiratory distress. So as the baby is a low birth weight baby, so whenever you go for an delivery resuscitation, you should be prepared, because these babies may require positive pressure ventilation. So your team should be alert so that somebody who knows in the intubation should be present at the delivery. So, and at resuscitation, so take care of the temperature. As we know, temperature of the baby is very important, which is going to affect the morbidity of the mortality of the baby. So temperature management, as we all know, these babies have more large body surface area, and they have very less subcutaneous fat developed, and brown fat it also less. So they are at more risk of hypothermia. So we should see that you maintain the temperature of the delivery room. If it is going to extreme preterm baby less than 32 weeker, we see that we keep things ready for maintenance of temperature, like cling wrap, head cap, all those things. You should keep it ready. And another important problem what we face when you have a low birth weight baby is a feeding difficulty. One is the mother will not be confident, as the baby is very small, how to hold the baby and feed the baby. Maybe you have to teach different feeding positions and help the mother from the beginning. If the baby is stable, you have to help the mother and baby by putting on early initiation, skin to skin contact. And maybe this baby may come to NICU, so you should counsel the mother about expression of breast milk. And low birth weight babies maybe have to be put on paladai and gavage feeding before they are shifted to the mother for direct breastfeeding. So they have a lot of feeding difficulties, and you should make sure that you are established feeding before you discharge this baby or ship the baby to the mother side. And one of the common morbidity what we see when you have a low birth weight baby is a respiratory distress. So you should see that you take a TP's resuscitator to the delivery room. If required, if the baby is having respiratory distress, you start the baby on CPAP and ship the baby. These babies are at high risk of developing, they may require surfactant. So other metabolic problems which we see in the low birth weight babies and hypoglycemia, because they have less glycogen stores, and they may have hypothermia and feeding difficulties. All these predispose this baby to develop hypoglycemia. And if the baby is born preterm less than 34 weeks, they have other risk of hypocalcemia. And one of the major complications when you have a preterm low birth weight baby is an infection. So you all know that these babies' immune system is less developed, and we do so many interventions in the NICU for keeping an IV cannula, feeding. So which we are not using proper feeding, then these babies are at risk of getting infection. So, and one of the major reason for death in these babies is sepsis, late onset sepsis. So we should take all precautions to when you're taking care of a low birth weight or preterm babies. And these babies are also at risk of developing jaundice. One is because of feeding issues, and other thing is mainly it is due to feeding issues. They are at high risk of jaundice. So these babies has to be monitored for jaundice. And when you have a preterm baby, the other complication, what we see is a extreme preterm baby. They're at risk of, because their germinal capillaries are not very immature. They are at high risk of IVH or periventricular leukomalacia. So our handling of these babies should be gentle. So when you are intubating the baby, or when you are resuscitating the baby, or when you are shifting the baby to our SNC or NICU, we should take all the precautions. Otherwise, these babies end up developing IVH. So another important morbidity what they face is apnea of prematurity because of immature respiratory center in these babies. So before you label as it as apnea of prematurity, you should see that other causes like hypoglycemia, hypothermia, sepsis, everything is ruled out. Then only we can brand this baby as having apnea of prematurity. So now we have babies who are less than 32 weeks. We have to start early caffeine for this babies, which has been proved helpful in apnea of prematurity. Another important problem which we see in preterm low birth weight baby is, especially in preterm babies, anemia of prematurity. One of the main reason is sampling. So we take multiple samples for the babies, take blood, CPP, blood culture. We send repeated electrolytes. So these babies are at risk of iatrogenic anemia. We should see that wherever it is possible, use non-invasive technique, transcutaneous bilirubinometer. You see that you are planning your blood samples. You use minimal sampling techniques so that you decrease the incidence of anemia of prematurity. And anemia is also one of the major risk factor for retinopathy of prematurity. So we have to see that the babies are maintained in the target hemoglobin levels. And one of the major thing which we should never forget when you're managing low birth weight or preterm babies, screening these babies for retinopathy of prematurity. So according to the guidelines of India, all babies who are born less than 2 kgs should undergo retinopathy of prematurity screening within first 1 month of life. Irrespective of the complications, you see that you are screening, because we all now get to see so many of medical legal complaints that baby was not screened for ROP and baby has lost vision. We should know that these babies are not born blind. It is because of prematurity on various things which we do in NICU, like sepsis, giving more oxygen, not titrating the oxygen support during the NICU stay, and multiple procedures. And these babies are at risk of retinopathy of prematurity. We should document that parents have been counseled about retinopathy of prematurity, give that appropriate date when the screening is done, and also educate that it is not one screening. They have to follow and screen the baby till the retina gets mature or the rest regressing ROP. So this has to be documented and signatures have to be taken, and in the discharge summary also, you have to document it. Another problem morbidity is hearing, because these babies are exposed to multiple drugs like autotoxic drugs in NICU, sepsis, meningitis. So these babies are at risk of developing hearing loss. So all the babies, irrespective of risk factors, should be screened before discharge for hearing. So since we get falsely report, better to screen at 34 weeks. And if their screen is comes at refer, you see that you follow the baby within the next 1 month, and early intervention is started. Apart from these short-term and morbidities, these babies are at also risk of long-term complications like high risk of cerebral palsy, cognitive impairment, and behavioral and and chronic health issues. So preterm babies are at high risk of diabetes and hypertension. You educate them and you see that these babies are not followed up for a long time. So these are all the various problems which a low birth weight baby can face during the stay in the NICU or during the follow-up. We can have a break or one or two. I have some questions for you. Can you classify what are the reasons for low birth weight? Two types of classification. Why a baby is low birth weight? Please answer in the chat box. What are the types of low birth weight? Why a baby could be low birth weight? So the reasons the babies are low birth weight is what is that? They are born. Yeah, Upadhyay answered preterm. So the reason could be preterm. What is the other classification for being low birth weight? Good. There it could be due to small for gestational age. Vamshi has answered like prematurity and small for gestational age. Yeah, good. So what growth charts you will use at birth to know whether the baby is SGA, SGA or LGA? So what is which growth chart you will use? So you can answer. So yes, good one. You can use a Fenton chart. Fenton's chart. The another chart which you can use a intergrowth chart. So you can use either a Fenton's chart or intergrowth charts. So when do you say a baby is a SGA baby? If the weight of the baby is below what percentile, then you call the baby as small for gestational age? So you can, yeah, less than 10 centile. Good. Sadhana's answered 10 centile. So I think everyone is listening to so less than 10 centile. So I will give an example. I don't, just wait a second. So I think now we can continue. Till now we have seen what are the problems of preterm low birth weight. We'll also see what are the complications a small for gestational age baby will have. So one of the complication for a small for gestational age baby is a fetal distress because of chronic in utero hypoxia. Small for gestational age babies are at high risk of birth asphyxia and meconium passing of meconium in utero. So you should be very vigilant. You should see that your team is prepared for resuscitation whenever you are attending a baby which is small for gestational age. High risk of birth asphyxias are there. Their Apgar scores will be low. You have to give positive pressure ventilation. So you should know that you see that the ambu bag is functioning. You have another person who can help you in the resuscitation of the baby. And another complication for a small for gestational age baby is a polycythemia. Because of chronic in utero hypoxia, they have high production of erythropoietin and they have high risk of polycythemia, which can manifest as shock, a feeding intolerance, metabolic acidosis, hypothermia, hypoglycemia. So you have to monitor for hematocrit in these babies. Another is hypothermia, because as you know, these babies are going to have less brown fat and adipose tissue. They have more risk of hypothermia. So you take all the precautions so that you maintain the temperature of these babies. And because of less glycogen stores, these babies are at also risk of hypoglycemia. So you see that these babies are monitored for blood sugar levels. As we all know, though, that hypoglycemia is one of the morbidity which can have a very bad prognosis. So as a pediatrician or a neonatologist, we should see that we avoid prevent hypoglycemia, because as it is very bad neurodevelopmental outcome. So you have to educate your nursing staff to monitor blood sugar levels and treat appropriately. And also see one of the reason the baby could be SGA is that underlying some anomalies, either a chromosomal anomalies, or the baby is born to some mother with SLE. Also, you have to see whether torch infections are one of the reasons for SGA. So look for any associated malformation in these babies. So once you're dealing with a low birth weight or a small for gestational age baby, or if you know antenatally, you have to better deliver, refer the mother in utero, because once a baby is delivered somewhere and shifted, then there are so many complications during transport, like baby may high risk of developing hypothermia, hypoglycemia, then other complications like IVH if it's an extremely preterm baby. So better to prefer in utero transfer, and you should refer to a center where they can take. So if the baby is going to be an extremely low birth weight baby, refer to a center where there's a medical college where they have a ventilator, surfactant. If the baby is going to be around 1.5 to 1 to 1.8 kg, then you can refer to an SNC. So before shifting the baby, see whether that center is equipped to deal with such a baby. So how do you, but majority of the babies can be, low birth weight baby can be saved by simple intervention. We should all know that we have high incidence of low birth weight babies, but not all these babies require high equipped equipments like ventilators, surfactant. There are so many babies who require basic care. That includes kangaroo mother care, early initiation of breastfeeding, giving expressed breast milk, teaching mothers how to feed the baby, how to keep the baby warm, explaining the mother about the danger signs, and preventing infection. So these are some of the essential things which can save majority of the babies. But there are some low birth weight babies which require a level 2 and level 3 care. So one of the important thing is how to keep a baby, you have to educate the mother how to keep a baby warm. So if the baby is stable, please educate mother to keep skin to skin contact. As we all know, it has so many benefits, and she should also see that the room is warm, to maintain the temperature of the room where the mother and baby is there. Especially in winter months, you see that baby is adequately clothed with 2 layers of cloths with 8 socks and mittens, and mother to be trained how to look for a cold stress. Like she should be educated how to examine the for colds like center and periphery. She should be educated. So if the baby is like a sick baby, not stable, then the baby has to be kept in a radiant warmer or a incubator. So first important thing is, as we all know, temperature management. Then comes the feeding and the fluids. We should know that depending upon the gestational age and the weight of the baby, we feed the baby. So for example, you have a baby who is less than 30 weeker and baby is less than 1200 grams. These babies cannot be started on a paladay feeding or breastfeeding, because they are immature, their sucking and swallowing is not mature. So that's why we should know the correct gestational age of the baby, so that you decide what technique of feeding you should give. So if your baby is born at less than 30 weeks, these babies should be started on gavage feeding in the initial days. Then slowly, as the age of the baby increases, then you can try spoon feeding, then breastfeeding. So it should be a gradual step. Then if you have a baby who's 1200 to 1800 grams, or between 30 to 34 weeks, so these babies, they can do swallowing, and but they may not be able to suck on the breast. This is we should all know that this is a rough guideline. It depends on the sickness of the baby and individual baby. Sometimes we see babies who are 36 weeks, even if they are put on the breast, they may not able to suck. So based upon individual baby, you have to assess the baby, put the baby, and then decide whether this baby can be put on the breastfeeding, or this baby needs spoon feeding or paladay feeding, or whether this baby needs gavage feeding. If the baby is more than 34 weeks, then the baby can feed directly, but that depends upon individual babies and individual mother, because some mothers, they may need more support to feed the baby. So as the age of the baby increases, then you can try feeding. Another important is, if you have a baby who is a stable baby more than 34 weeks, see, try to avoid IV fluids. As we all know, once you keep an IV cannula and IV fluid, there is more risk of infection. But if your baby is less than 34 weeks, where you have to start fluid requirement, then you should know how much fluid you should start. So we all know that first 2 days we should start 10%. Loss. Per day, they should not use more than 3% weight loss. Now, especially in summer, I am audible. Now, especially nowadays in summer months, we see many babies having a dehydration. So you have to daily check the weight of the baby. Unless you don't take the weight of the baby, we don't know whether the baby is losing physiological weight or pathological weight. So see that you take the weight of the baby and then plan the fluids accordingly. So low birth weight can lose up to 1 to 2% weight loss, and it should be cumulatively they can lose 10%. But if the baby is losing more than 3%, you should be very careful, and they should regain birth weight by day 14. After they regain the birth weight, then they start gaining weight around 15 to 20 grams per kg per day. So this is one of the common thing what postgraduates have a problem is, whenever you have a baby who is having a Doppler abnormalities. As we all know that whenever the baby is a fetal growth restriction, antenatally they do scans and see whether there is an abnormal Doppler. So how do you deal when you have a baby who is less than 35 weeks but at an abnormal Doppler? So Doppler in the forms of either it is reversal or absent end diastolic flow. So if you have a baby who is less than 35 weeks and reverse end diastolic flow in the antenatal scan, then you keep the baby NPO for 24 hours. During this period, observe the baby, whether the baby is having abdomen distension, vomiting, or the abdomen is soft. We see any loops of the abdomen. Then you start the feeding. You do baby's abdomen is soft, no vomiting, baby has passed out. Then you can start feeding the baby. Start at 10 to 20 ml per kg. If it is tolerating, then you can increase the baby. So then depends upon the gestational age, whether it is less than 26 weeks, 26 to 27, 28 to 30 weeks, or the baby is more than 30 weeks. So this has been shared in the WhatsApp group. Please go through it. Another common thing what postgraduates do is, if they have one episode of vomiting and one episode of abdomen distension, they continue, you end up keeping the baby's NPO for long time. Don't keep like that. Reassess the baby, whether the abdomen is becoming soft, baby is passing stool, no bilious aspirate. Try to start feeding early, so that we all know early feeding is going to help the baby. Early feeding, early the baby will get discharged home, and less risk of infection and less risk of NAC. So look for these abnormal signs where you have to keep the baby NPO. If the baby is having very severe distress, or say multiple apneas, or recurrent seizures, or shock recurring multiple inotropes, in those times you can keep NPO. Otherwise, you have to start feeding for the babies. Another important thing is, once you start maintain the temperature of the baby, start feeding. As we all know, breastfeeding is best for the babies. Try to give breastfeeding. If the baby is low birth weight, ask mother to express the milk and sell the milk. If the mother is not getting adequate milk, try to get donor milk. If you have a milk bank, the next best option is giving donor milk for the low birth weight babies. So once then, supplements. We all, as a postgraduate, we should know which all supplements you have to start. You know that baby breast milk is deficient in vitamin K. All babies, they should get vitamin K at birth. For babies less more than 1 kg, 1 mg, less than 1 kg, 0.5 mg. Vitamin D, 400 to 1000 international units. Start once the baby is 100 ml per kg per day. And vitamin D should be given till 1 year of age. And you should start early iron therapy for all low birth weight preterm babies. Start at 2 to 4 mg per kg per day. Start from 2 weeks and give to 1 year of age. Multivitamin drops, if your baby is less than 1.5 kg, give 1 ml per day. And calcium and phosphorus, if your baby is less than 34 weeks, start at 120 to 140 mg per kg per day. Once the baby is 100 ml per kg per day. So when you discharge the baby, so you should see the first important thing is mother is confident, baby is stable, baby is able to take direct feeding or stable on taking spoon feeding, as showing consecutive weight gain, free of illnesses. See that supplements have been started. It is not only started, they should be tolerated. Sometimes we see babies started on multivitamins, vomiting, developing abdominal distension. So see that supplements are being tolerated. You explain about immunization. See, once the baby is stable, give immunization. And mother has been educated about kangaroo mother care and danger signs. Then only you can discharge the baby. Once you discharge, ask them to come for follow-up. And you should also educate the mother about the danger signs to the mother, like respiratory distress, not feeding well, tell they should report one. Where they should report, you should also educate the mother. And as I told, as these babies are at high risk of neurodevelopmental abnormalities, serial follow-up should be there. Depending upon the high risk, whether your baby is high risk, medium risk, or low risk, you should tell appropriate follow-up. And every visit, you should see that weight, height, length, head circumference is monitored and put on the chart till 40 weeks. You can use Fenton's or intergrowth charts. After 40 weeks, you have to use WHO growth chart. See that ROP screening, hearing, ultrasound is being screened and documented in the case sheet. And thyroid screening is also done irrespective of the risk factor in the baby. All the screening should be done. So every visit, you see that you also ask about the developmental milestones. And as we all know, prevention is better. So we should have a very good rapport with the our gynecologist team and see that they give antenatal steroids for preterm deliveries between 24 to 34 weeks. Government of India recommends dexamethasone 4 doses, 12 hours support. See that the mother has received dexamethasone. And you also document in the case whether the mother has received this. This is benefit if it given 24 hours prior to the delivery. And we also recommend all preterm deliveries less than 32 weeks. Mother is received max sulfate for neuroprotection. So these things should be inquired in the history and documented in the case sheet. So that's the end. So all the low birth weight and preterm babies can be managed with simple interventions. Majority of the babies can be managed if the mother is educated about kangaroo mother care, breastfeeding, how to take care of looking for danger signs, and the prevention of infection and hygiene. And all these cannot happen without we all know the essential care of the low birth weight babies. So thank you. And if any questions, you can unmute or you can put it in the chat box. So few questions. So you are having a preterm baby who is born at 34 weeks, now ready for discharge. So what are all the supplements you will start if a baby is 34 weeks? You can put in the chat box. Baby is with 34 weeks, born at 34 weeks, stable, ready to get discharged. Please kindly put it in the chat box. And any queries also, kindly feel free to ask. So Vamshi has answered like vitamin D and iron. Any other thing? Vitamin D, iron. So how much iron you will start? So what is the dose of iron? So if your baby is less than 34 weeks, you should also start calcium and phosphorus in the ratio of 2:1. So one important thing, we have to see the calcium syrup which you are advising, because sometimes we see calcium syrups, they don't have phosphorus. So whichever brand you are advising, please see that it has both calcium and phosphorus in the ratio of 2:1. Good iron should be started at 2 mg per kg per 2 to 4 mg per kg per day. Till what year you will, till what age you will give iron? So till 1 year of age. Yeah, so you should see that you give till 1 year of age. So below what birth weight you will screen for ROP screening? So Amruta's answered as 2 kgs. So all babies were less than 2 kgs. Uh, so you want us to explain the fluid chart in the PDF? I'll just so I will just open the uh, the fluid depends upon what is the weight of the baby, whether the baby's weight is less than 1.5 kg or more than 1.5 kg at birth. If you can open the chart, we can discuss once. I'll just open it once. You means to say that WHO, that flow chart. See, day 1, day 2, day 3, day 4, day 5, day 6, day 7. So, for example, your baby is 1000 to 1250 grams. So, you start the baby on the day 1, 80 ml per kg per day. So, the baby is on day 2, you make it 100 ml per kg per day. For example, then you are starting feeding. For example, you start 10 ml per kg per day. For example, you are starting and baby is tolerating. Then from that fluid requirement, you have to minus that feed. For example, you have 1 kg baby. On day 2, the baby should get 100 ml per kg per day. So you have to give it in the syringe pump over 24 hours. And if you have started 10 ml feed, you have to minus the 10 ml so that the baby receives 90 ml over the next 24 hours. So for example, then it comes day 3. Day 3, you have to make it to 120 ml. But this is a rough guideline. If the baby, then you have to take the weight of the baby. If the baby weight is losing 1 to 2 percentage, you have to increase according to this table. If the baby is losing more weight, then you have to add the fluids. You cannot just increase 20. Based upon the weight, you have to increase the fluid volume. So I think I have clear pattern. So take the weight of the baby, take the day of life. If you have a baby who is more than, like for example, 32 weeker, baby is 1.5 kg, then on day 1, you have to start 60 ml per kg. Day 2, you have to increase 80 ml per kg. Day 3, you have to increase it 100 ml per kg. Based upon that feed what you are giving, you have to minus the feed and give the fluid. That is how you decide the fluid of the baby. Any other questions? Whenever you attend the delivery call of the preterm low birth weight, you have to explain to the mothers and the attenders not only the condition of the baby, you should also explain about early expression of breast milk, that she has to express the breast milk and send it to an NICU or SNCU. And you educate the mother to come to NICU as early as possible and start early
उसका तबस्सुम का टेम्परेचर मॉनिटरिंग है वहां पे लिख के जाओ आप कर दोगे करवा दोगे
so once the mother comes to NICU, you encourage mother to test to chest.
तो उसका टेम्परेचर मॉनिटरिंग अगर ज्यादा टेम्परेचर लग रहा है अभी मैं अब 6:30 बजे
Confidence
साढ़े 6 बजे का है अगर कभी भी लग रहा है कभी भी अभी बीच में बुखार है अभी भी 100 है हमने में अब फिर से 2-3 घंटे के बाद जब आएंगे तो हमने लिया ना 7 बजे 10 बजे उनको लेने को बोलना और अगर ज्यादा लग रहा है तो नीचे भिजवा देंगे 12:30 बजे के बाद पहले हम फोन नहीं देते
Any other doubts?
भिजवा देंगे
Dr. Shruti, please.
टेम्परेचर मॉनिटरिंग तो करना ही है अगर इतना हाई चल रहा है तो नीचे भिजवा देंगे but I have waited.
Up to what age we continue multivitamin? So till the baby reaches term, it is enough. You can give multivitamin drops. Calcium and phosphorus you give till 40 weeks of gestational age. But you should also screen for osteopenia of prematurity. If your baby is in osteopenia of prematurity, then till it gets normalized, you have to give. Otherwise, babies who are born less than 34 weeks, you have to give till 40 weeks of gestational age. And it should be given in the ratio of 2:1. If you are giving like fortification HMF, you have to see how much the baby gets from HMF. Depending on that, you can add calcium and phosphorus. And you should also see each syrup has different composition. Some syrups have 125, 125 mg for 5 ml. Some syrups have 150 mg for 5 ml. So please see to the syrup. So the DHA doesn't have that much role. Long-term effects are not much different. So some formulas are coming up. They have DHA for brain protection. But whatever the DHA is there in the breast milk, especially for preterm mothers, is enough for the baby. What is the dose of phosphorus? 60 to 90 milligram per kg is the dose of phosphorus. So 120, 150 is the calcium and 60 to 90 mg per kg is the dose of phosphorus. See, all babies who are less than 32 weeks, see that a screening is done for osteopenia prematurity. Around 4 weeks, you have to screen calcium, phosphorus, and alkaline phosphatase. And try to start supplements, all the supplements, once the baby reaches 100 ml per kg per day feeds, you try to start supplements for these babies. See, Simil MCT oil, because one of the major thing what we needed for preterm low birth weight babies is a protein. Simil MCT oil is a fat. So we are not routinely recommending Simil MCT oil for low birth weight babies unless the baby is having a BPD, where you have given enough protein, still the baby is not gaining weight, or where you want to restrict the fluid requirement. In such cases, rarely we are using Simil MCT. Routinely, we don't advise Simil MCT for the babies. Thiamine deficiency per se, if the baby mother is on rice-based diet, completely on rice-based diet, then we see babies, especially we see in babies who are term babies presenting with sudden respiratory distress, pulmonary hypertension, where you have ruled out cardiac condition like cardiac defects. then there you have to suspect thiamine deficiency. Per se, in preterm low birth weight babies, we don't routinely screen for thiamine, but we see babies having thiamine deficiency, wet beriberi, cardiac beriberi, in term healthy babies presenting features like pulmonary hypertension, respiratory distress. Around 4 weeks to 6 weeks of life, babies present with thiamine deficiency. While calculating GIR for hypoglycemic neglect, the oral feed should be excluded for the total fluid requirement. See, that also depends upon the gestational age of the baby, especially when you are dealing with extreme preterm babies, your total feed should be minused because they are at high risk of PD and BPD. Whereas when you are dealing with the term babies, that doesn't much role of reducing the oral feeds. But if you are dealing with the small preterm babies, if you are giving a significant oral feeds, then you have to minus it from the total fluid requirement. See, HMF should be started once the baby reaches 100 ml per kg per day. For preterm babies who are less than 32 weeks, we have to start. Then you have to see that till the baby reaches 2 kgs, you can give HMF. But what we see is if your baby is growth restricted or your sepsis rate is very high, then you have to see the tolerability. So for each 25 ml of HMF, see mother's milk, you have to add HMF. 25 ml of express breast milk. Now we have HMF sachet which comes in 1 gram sachet that we have to give full standard fortification. There are 3 types of fortification. We can add HMF to 25 ml of mother's own milk or a donor milk. We routinely don't advise MCT oil. Instead, you give mother's milk and HMF sachet if the baby is less than 32 weeks. Especially you have a baby, you have BPD requiring respiratory support, you are adding HMF, still baby is suffering to get. In such cases, we add MCT oil. Role of probiotics in reducing NEC. There are a lot of evidence saying probiotic in reducing NEC, but it depends upon which strain you are using and what is the dose. Where you have to use multi-strain probiotic in order to reduce the incidence of NEC. So, but the best probiotic is giving mother's own milk and starting early and rapidly increasing the feeding so that you reduce the infection rate in NICU so that babies have less NEC. So, breast milk protects not against NEC, it also protects against BPD, it also protects against retinopathy of prematurity. We should know that each ml of breast milk is going to have so many advantages for the preterm low birth weight babies. Amino. Yeah, proteins are very much essential for aminoin is essential for preterm extremely low birth babies, especially if your baby is not going to reach early feeding. Extreme preterm babies less than 28 weeks, you have to start amino proteins based upon the gestational age. If your baby is less than 28 weeks, then we have to start 4 to 4.5 grams per kg per day. As we all know that protein in the first week of life is going to have an impact on the later neurodevelopmental outcomes of the baby. So if your baby is not going to reach significant feeds, and if the baby is extremely preterm babies, you have to start proteins so that you don't degrade the protein what the baby is going to have. So protein is very much important because if you give only dextrose, the baby is not going to get any protein. And extreme preterm babies require 4 to 4.5 grams per kg per day protein. So we have 10% aminovin. We have to start for extreme preterm babies, or from 28 to 32 weeks. If you think the baby is not going to reach significant speed, then you have to start early total parental nutrition. Any other questions? Kindly put it in the chat box. Caffeine, early caffeine, we have to advise for babies who are less than 32 weeker or less than 1250 grams. Early caffeine has been found to be helpful against BPD. BPD. So early caffeine has to be started. Various trials have shown early caffeine is helpful. Especially for babies less than 32 weeker. Please explain GIR and total feed. See, for example, you are starting GIR for the baby. Babies having hypoglycemia, you are starting a GIR for at 6 mg per kg per minute, and you have the fluid requirement of the baby is 80 ml per kg. For example, you are taking 1.2 kg baby on day 1 of life, the fluid requirement is 80 ml per kg. So if your baby is having hypoglycemia, you start the GIR 6 GIR. So you have started GIR. At the same time, you should also see that if the baby's abdomen is soft, then you also start feeding for the baby. For example, you have started 20 ml per kg per day. Then you have to monitor the baby blood sugar level for 24 hours. The baby is maintaining GIR. For the next 24 hours, the blood sugars are in the target range. The baby is tolerating 20 ml per kg per day. The next day, you have to reduce the GIR. In that case, you can reduce the 20 ml feed from the total fluid volume. For example, the next day, the baby is going to reach 100 ml per kg per day feed fluid you have to start. In that case, this 20 ml, you can minus it from 100 ml, then it comes 80 ml. Instead of since previous day you have started 6 GIR, the next day you should see that baby is tapered to 4 GIR. So as the feed volume is increasing, and if the baby is tolerating feed, you have to reduce the volume of the feed and decrease the GIR. Caffeine, sometimes we also start for preterm babies who are more than 32 weeks. That depends upon case basis. Routinely, we don't start. But if you have some babies who are more than 32 weeks developing apnea, we start caffeine. Not for all cases. Can we start feeds in case the baby is on CPAP, HFNC? You have to must start the baby once the baby is CPAP or HFNC is not a contraindication for feeding. You are going to give a feed through the feeding tube when the baby is on CPAP or HFNC. You have to start feeding. Otherwise, baby will be highly irritable for feeding. Then they will not keep your CPAP cap or HFNC prongs. You have to start feeding. See that the feeding tube is closed for next 1 hour after keeping feeding. Then open the feeding tube end so that you don't develop abdomen distension. No contraindication for feeding if the baby is on CPAP or HFNC. The only contraindication is whenever you are suspecting NEC, necrotizing enterocolitis, or if the baby is having some intestinal problems like intestinal atresia, or babies having bilious vomitings or blood in vomitings, then only you have to stop feeding. Otherwise, you have to keep feeding. Only when the baby is on feeds, babies on CPAP will be comfortable and stable. Otherwise, they keep on moving and highly irritable. Any other questions? I think if feeding tube end level above or above the abdomen. Better is above the abdomen. Feeding tube. See, when you're taking care of low birth weight babies, please don't forget about ROP, kangaroo mother care, breastfeeding, infection prevention, reteaching danger signs for the mother, and involve mother from the beginning in the and developmentally supportive care. One thing which I want to ensure is non-nutritive sucking. Say once the baby is on even on the gavage feeding, you can start once the baby is stable. You can ask the mother to keep the empty breast of baby to be put on mother's empty breast. So once the baby keeps on sucking on the empty breast, the sucking of the baby will improve. The mother also will get more milk. The establishing breastfeeding also will be better. Because one of the common problem mother gets milk. One is she has to express the milk. Many times, even if she express milk, she may not have a sufficient milk. In that case, all the babies, if they are put on the mother's breast, the sucking of the baby will make the mother to produce milk. So these things should be taught to the mother, early non-nutritive sucking for a low birth weight babies. And prolonged skin to skin contact, not like 1 to 2 hours, 12 hours. If the mother keeps the baby on skin to skin contact, she can get more milk. See, Bob, you got few points. If there are no questions, we can close. Or if there are questions, please put in the chat box. I think there are no further questions. Then we can call for the day. Thank you for joining. And any question, please put up in the chat, in the WhatsApp group. Thank you. Thank you one and all for joining this evening. Thank you.